Yeah, yeah. Okay. Um, we'll first go through the objectives that we are going to present in this presentation. First, we'll be looking at the definition of Parikharthika. Then we'll go through various references that we have in Ayurvedic text related to Parikharthika. Then we'll study Nidan, Samprapti, and Lakshana and Sadhya of this disease. And finally, we'll go through the Chikitsa of Parikharthika. Okay. So the fissure now is one of the most commonest entity that we actually encounter in our practice. And the thing is that there is no disease mentioned in that particular context. So the symptom, the Parikharthika mostly comes as a symptom or a complication of various diseases or procedures like Panchakarma. That is what Parikharthika is. So let's go through the definition of Parikharthika. Parikharthika actually has two terms in it. One is Pari and the other one is Kartana. The Pari means all around or surrounding, and Kartana is an act of cutting or act of cutting with scissors. It basically means there is a pain which will mimic cutting, or there is sharp shooting kind of pain in the region of Guda. Not specifically Guda, but in other regions also, like Nabhi, Basti, Vangshan, or perianal region. So there is sharp pain you'll feel in this particular disease. Moving on to the next slide, we'll try to cover up various references that we have in Ayurvedic text related to Parikharthika. So the first one is Vaman and Virachan Vyapad. Okay, you'll find that Parikharthika is prominently presented in the headings of Panchakarma Vyapad, like Vaman Vyapad or Virachana Vyapad, or even Basti Vyapada. It seems that disorders like that, like Parikharthika, were not common those days, probably because of natural food or healthy living. Today's the lack of processed food or healthy environment in those days, and lack of sedentary lifestyles may have this disease rare in those days, I guess. And the reason why this symptom comes in the conditions where improper defecation is evident. Panchakarma Vyapad is one such condition where you will find this kind of disease. Here, Vaman and Virachan Vyapad, or Ati Yoga, to be precise, is mentioned as a reason for Parikharthika. We'll just go through the concepts they have mentioned in the shlok. There are three conditions they have mentioned over here. First shlok, if we'll go through the first shlok, you'll find that Snigdhena Guru Koshtana. They say that if person who has completed his Snehana, who is having a Guru Koshta and Samdosh. Second condition is if the person is Kshin, or he's having Mrudu Koshta, he's tired, that is Shanta, and is having Alpabal. If these patients are treated with Balwan Aushad or heavy medicine, what is going to happen is all the doshas or Sam doshas are going to come out through the anal region or Guda with Tivra Shul, severe pain, and mucus and blood discharge, causing Parikharthika. That is one condition. And similar condition is mentioned by Sushruta. He says that in same patients, if you treat these patients with Ruksha or Ati Ushna or Ati Lavan medicines, this is going to cause a Vat and Pitta Prakop, and ultimately it will result in Parikharthika. Also, you'll have the pain in Guda, Nabhi, Medra, Basti, Shir, and you'll have symptoms like Aruchi also. Moving on, the second reference that we have is in Basti Vyapada. Here you'll find in these references, if the person is treated with Ati Tikshna, Lavan, Ruksha Basti, there is going to be Prakop of Vata and Pitta, and it is going to cause Parikharthika. That is what the first shloka says. In second shloka, Sushruta says that if the patient is having Mrudu Koshta and he is having Alpadosh, and if you treat this patient with Ruksha or Tikshna Basti, or with excessive quantity of Basti, that is going to cause Parikharthika. And in last shloka, they explain that excessive use of Yapan Basti is going to cause Parikharthika. Okay. From all these examples, you can see the importance of Koshta and Vata Pitta Prakop. That is very much evident in all these references. Okay. Moving on, Parikharthika is also mentioned in context or in relevance of various diseases. We will just go through the diseases that in which Parikharthika occurs as a symptom. The first one is Arsharoga. Okay, so in Arsharoga, you find Parikharthika as a prodromal symptom or a Purvarupa, or even as a symptom in Vataj and Kafaja Arsha. Actually, Samprapti of both these disorders is pretty similar. I mean, to a certain extent, it is very similar. The stotuses that are affecting these both diseases, like Arsha and Parikharthika, are same. that is Purishvaha and Anvasvatas. And the area of presentation or Vyakti of this disease is same, Guda. And also in our routine practice, we find that these both diseases are very much associated. I mean, the patient having hemorrhoids is also having fissures, or fissure acts as a precursor to hemorrhoids. That is the condition that we notice in our day-to-day practice. So it is very obvious that these both diseases are closely related. The next reference that we find is of Vataj Grahani, where even Parikharthika occurs as a symptom. I believe that Parikharthika usually has a relation with Grahani because Grahani is most important disorder affecting Annavasvatas and Agni. And also the modern entities like ulcerative colitis or Crohn's disease or other inflammatory bowel disorders, which we closely relate with Grahani, are oftenly associated with fissures. So again, this is very obvious that these two diseases have to be related. The next reference that we have is in Vataja Atisara. The Parikardika is again a symptom in this. And if we try to relate it with the modern concept, diarrhea, so after having repetitive episodes of diarrhea, you will find that sphincters lose their ability to dilate and they go in spasm, ultimately causing fissures and nano. So diarrhea is again one cause that causes fissure. It has been covered in our Ayurvedic literature. Okay. In Purisha's Udavarta. Udavarta is actually suppression of natural urges. In these cases, I mean, the cases like suppression of Apanvayu or Purish, you'll find that the person will be affected by hard stools or difficult identification, which will ultimately result in Parikharthika. And the last one is Garbhini Upadrava. Again, we find that mostly pregnant women are affected by hemorrhoids and even fissures. The reason everyone must be knowing that there's an increased pressure of pelvis due to growing uterus on the organs that are located below umbilicus. That is the reason because of increased pressure, these people are going to have painful defecation and constipation like symptoms. Okay, moving on, we will be looking at the nidana. What are the various causes for this disease? So we have covered in previous disorders, but as we have described it earlier, that Panchakarma Vyapada is one of the main cause for Parikharthika, like Vaman Virachan Atiyoga or improper administration of Basti. That is the one hetu you can say. Then various vyadhis like Arsha, Atisar, Jwara, Udavarta, and Grahani, as we have seen earlier, will be the main reason for Parikharthika. Even Arsha, Atisar, and Grahani are Anyona Nidana Bhuta vyadhis. The one disease is going to cause other. Okay. And we also should not forget that all the hetus that can cause Arsha, Atisar, or Udavarta or Grahani are going to cause Parikharthika. Okay, so these all disorders and their symptoms will be causative factors in Parikharthika. The next one is Vega Vidharan, the suppression of natural urges that we have seen. Vishamasan. Vishamasan means improper dietary habits. If you're having very guru or ati ruksha, ati lavan, ati snigdha kind of a diet, or you're having adhyashan or ati matrashan, that is ultimately going to cause Parikharthika by affecting Agni and your overall gastric disturbances. Ati Pravahan is one of the reason in this cause. See, Ati Pravahan can result from two conditions. One is if patient is having a problem in defecation. In that case, to pass the hard stool, patient is going to exert a lot of pressure to pass the hard stools. And ultimately, it will cause trauma to the anal region. That is first condition. Second condition is that many people, in attempt of hurrying, try to empty the bowel rapidly. This is the period where people are mostly busy in their daily chores, and I guess there is not a lot of time for daily routines. So they try to hurry up every event, and this is the one condition where people try to exert a lot of pressure to difficult. So that is one condition, and the last one is Visham Asana. Sitting in improper ways is also going to cause Parikharthika. The most common reason that we see today is sitting for longer hours or longer time in toilets. That is one condition. We are having now commodes and all kind of toilets, so people are spending so much time in toilets, sitting in improper positions. That actually exerts pressure on anal region and causes diseases like Arsha or fissures or hemorrhoids. The one reason, and even sitting in Utkardasan has been described as a reason for Parikharthika. Mental state is also very important in this condition because constant stress is prone to be associated with gastric disturbances. Subhaya, Shoka, Krodh, this basically comes in Ajirna and also Grahani or Atisar, these conditions, which are ultimately going to disturb your gastric or GIT and then again going to cause problems in anal region. So these are the Nidana. We will look at the Samanya Rupa, how this disease actually is presented. Okay. The first one is there is Kartanat Vedna. That is one thing, a main and prominent symptom that you will find in Parikharthika. The pain persists before and after defecation. There is one symptom. Secondly, there is Raktasrava. It is very obvious because this condition is associated with Vrana or ulcers. And whenever the motion friction, have a friction on this ulcers, it is going to free the edges or fresh the edges of the ulcer and then bleeding will start. The next is a discomfort in perianal region. Then, yeah, we have discussed Vrana. This condition actually has a main symptom, Vrana. And there is Vata Sangha. It is difficulty in passage of flatus. It can be seen in the severe cases of fissure, or you can say Parikharthika, where there is severe anal spasm. And in these cases, patient is having problem in passing flatus. Then Adhman Aruchi because he's not able to pass his flatus. And then there is Kathin and Alpa Mala Pravritti. There is hard stools, which will be difficult to pass. And the last one is the Malavashtamba, that is constipation. So chronic constipation again results in exerting excessive pressure and causing fissures in anal region. That are the symptoms we have seen. Okay, Kashyapa has mentioned 3 types of Parikharthika while describing the treatment of Parikharthika. So he says that there are 3 main types. One is Vataj, Pittaj, and Kafash. This reference actually comes in Kashyap Saita. If we try to analyze the symptoms, we can associate Vidaran or Kartanat Vedna with Vataj Parikharthika. Daha and Raktasrav will be associated with Pittaj Parikharthika. And Kandu or mucoid discharge or Pichhasa can be associated with Kafaj Parikharthika. Let's try to build the Samprapti for this particular disorder. We have seen the Nidana. There are so many causes. One is the Panchakarma Vyapad. Then there are various Vyadhis like Arsha, Atisar, Jwara, Udavarata. And then there are important improper diet habits. 2 things are very evident because of this particular Nidan Sevana. One is there is going to be Agni Dushti. And second is there is going to be Vata Pitta Prakop, as we have seen in earlier references. And the presentation of this is going to be an Guda or anal region. This is one thing. So Agni Dushti and Dosh Prakop is going to happen. Dosh predominantly will be Vata and Pitta. Sthana Sankshay will be in Gudisthana. Okay, because of these conditions, there is one thing that is going to happen is the Mala is going to turn hard. There will be a Grathita Mala Pravritti, or you can say there will be Mala Vibandha because of damaged Agni and increased Vat or Pitta. It is going to cause Grathit or Mala Vibandha in this one case, and it is going to increase the Rukshata in Guda. See, for healthy condition in anal region or Guda Marga, some amount of lubrication is necessary. If you see the anatomy of anal region, you'll find there are anal glands which actually provide lubrication in that particular region. So this Shleshma is important. Now, in case of Vata and Pitta Prakop, that region actually has a tendency to create cracks. Okay, so the anal skin or the cutaneous region in the anal part will develop some cracks. So that is the first dhatu which will be disrupted. We can call it as rasa dhatu or tvak. Secondly, there will be rakta. Rakta dhatu will be affected and it will cause vrana. And subsequently, there will be bleeding. And the last one, the last dhatu that can be affected will be Maunsa. If Maunsa dhatu is affected, it will cause Maunsa Ankura that we can associate with sentinel tanks. Okay, so the dhatu dushti we find in this particular disease is Tvaka, Maunsa, and Rakta. Okay, so after dosha dusha samburshana, and then after that, the disease like Parikharthika will be formed. So this is actually Samprapti we can discuss. Okay, Sadhya Sadhyata. Now, considering the Sadhya Sadhyata in this particular disease, we should know that ulcer is a very prominent symptom in this. And I have taken the reference from Vrunadhyay. So looking at this, most of the vrana are very easily curable in Gudha region. Okay, if that vrana is left untreated, it may turn yapya or asadhya. Okay, now if superficial layer is affected, it is very easy to treat. But if deeper layers are involved, it will be very difficult to treat. Again, if the patient is having comorbid conditions like madhumeha, kushtha, or vishadushti, it will be very difficult to treat this condition. So that is sadhya sadhyata. Just have an overlook of the chikitsa. These are some kalpa which are mentioned in Ayurvedic text. One is the Pichavasti. You can see two references. One is from Sushruta, another one is from Charaka. They are using Madhur and Shita Dravya for creating Pichavasti and treating those conditions. Anuvasana is also there. Madhu Yashti, Ushira Gambhir. Again, Madhur and Shita kind of medicines are used to create that basti. A few references of Peya and Leha you will find in Kashyap Samhita. Again, this type of Yusha, like including Brihati, Bilva, or Anantamura, or Madhuyashti or Hansapadi, can be used for the treatment of Parikharthika as per Kashyapa. The first one actually is used in Vataj Parikharthika, and second one is used in Pittash Parikharthika. Okay. Now, treating this disease in our day-to-day practice, how can we actually treat these patients? So there are some treatment principles that I have formulated. First one is treatment of primary diseases. So we all know that Parikharthika is associated with these various disorders of Grahani, Atisar, and Arsha. So it becomes very much important to treat these all disorders. And you need to consider all these disorders before treating fissure. The second one is Agni. No matter how many times you treat Parikharthika locally, unless you don't treat Agni, it's gonna keep coming back. Okay, so treatment of Agni is very important than local treatment. Okay, you can treat fishes locally, but unless and until you won't treat Agni, it will again and again create the same problem. Third one is treatment of Malavashtam and Anuluman. Constipation and hard stools are main culprits in this disorder. So proper anulomana is very important part of the treatment. So one thing. Then Vedana Shamana. And now pain is a predominant symptom. Rather, it is a main description of disease itself. Or this disease actually is mentioned related to pain. So Vedana Shamana is a very important aspect of the treatment. The second one is Vrana Ropana. Ulcer that is formed should have a special attention, and there are some medicines which we can use for Varanaropana and Raktastambhana. If the patient is having bleeding per rectum, then we have to look for that symptom too. So now let's see what medicines can be used for this particular conditions. Okay, there are two types. One is general treatment and local treatment. General, like you can use internal medications, and for local you can use Matravasti, Anuvasana, Nadisved, Avgahasved, and there are excellent application medicines. Okay, so Agnivardhan and Deepan Pachana. These are some medicines which you can easily use for Agnivardhan and Deepan Pachan for the patients of Parikharthika. Trikatu Churna, Hingvashtak, Dadimashtak, Lavan Maskar, Musta, Agnitundivati, Chitrakvati, and Arogyavardhani. Mostly I use Dadimashtak. If the patient is having complaints of Agnimandya, patient complaints of indigestion, I mostly go for Dadimashtak with ghee half an hour before food. If patient complains of Anaha or Adhman, I shift towards Hingvashtak Churna with ghee. That is one medicine which will actually relieve gaseous distension and flatulence. So Hingvashtak Churna can be used for that. Arogyavardhan is a very important medicine because it is going to cause Deepan and Pachan. It also has Kutki in very large proportions. So it is going to cause Malabhedana. So it is having all-round effect in such conditions, Arogyavardhani. Musta is again one beautiful medicine. It can cause Agnivardhan. It is Grahi. So in patients who are having loose stools or in patients who is having Amla Pitta due to Dravaguna of Pitta, you can use Musta Churna. So these are very important medicines you can use. The second is Anulumana. Avipattika Churna is there, Swadishta Virichan is there, Gandharva Haitki, Panchasakar, Abhairishta, and Aragvat Kapila. Now, this depends on the Koshta of patient. If patient is Mrudu Kushta and is having very little symptoms, you don't have to actually use these medicines. You can try to treat that condition using some home remedies like milk or ghee or maybe manuka. You can use that. If patient is mrudu or crude koshta, you can go with these medicines. Okay. What I do is I use avipattikar churna if patient is having symptoms of pitta, or if patient is also having associated amla pitta. So for region of pitta, I use avipattikar churna. Okay. Also, the symptoms related to pitta like daha and these conditions can be treated using avipattikar. And avipattikar acts good Agnivardhan as good Agnivardhak medicine. So avipattikar. Second medicine that I use is Gandharva Haritke. It is an awesome combination. One is Gandharva means air in the tail, and Haritke is Anulomak. So in case of increased rukshata, some sort of snehan is very, or ovulation is very important. That Gandharva, that is your air and tail can provide. And Harit acts very good anulomak. So this is one medicine. And there are other medicines like Abharishta or Aragvat Kapila. If necessary, you can use these medicines too. I mostly use two medicines in combination, Gandharva Haritke and Avipattikar. That serves the role because we have seen that Vata and Pitta are predominantly playing role in this condition. So it becomes very much important using these two medicines in combination, Avipattikar Churna and Gandharva Haritke Churna. You can use that in combination. Okay, for Vedna Shamana, I mostly use Triphala Gugur for Vedna Shamana and Gandhakrasan. Gandhakrasan has an added benefit of treating Daha symptom. If the patient is having Daha, you can definitely go with Gandhakrasan. It acts beautifully. Secondly, Gandhakrasan is a medicine that is going to help to treat the wound as well. So it is one of the best medicines. And Avgaha Swed should be the part of your prescription. Every patient of Fissure should have hot sweat bath. Okay. Even though you don't have any sort of medicine, you can use plain hot or lukewarm water for Avgaha Swed. It is definitely going to cause relief in pain. First thing. Secondly, it will keep that area clean so that the wound will heal faster. Patient will have more relief. So Avgaha Swed is very important after every passage of motion. And Naduswell. Naduswell is also very important for pain relief purposes. Okay. Moving on, Vranaropana. That is one important aspect. I mostly use Sukshma Trifala for Vranaropana. It has shown significant relief in case of ulcers. And then Gandhakrasana is there. Trifala definitely comes in Vranadhikara, so you can use that. Local treatment is very much important in this aspect. What you use is going to be very important. What I prominently use is Shatadhauta Grut and Yashtimudha Grut mostly. Shatadhauta Grut is going to heal your wound. Secondly, it is having a soothing effect, so patient will be relieved from discomfort. Yashtimudha Grut also will decrease the burning pain, which is mostly the symptom in these cases. Then you can go with Jataritel, that is very good for healing wounds. Kasisadatel has a Ksharan action. So if the patient is having Dushtavran, Dushtavran in the case, it is a chronic ulcer and the edges of the ulcer or the Parikharthika have become hard, you can use Kasitadatel. Or you have to use it on the sentinel tags that will cause corrosion and then it will reduce that symptom to certain limit because Kasitadatel has come in Arsha Rogadikara. And again, Avgaha Swed, you can use that for Vranaropan as well. And last is Raktastambhana. These are some medicines which you can definitely use for Raktastambhana. Napkesha, Ludra, Amalki, Vasa, Durva, Bol Parpati, and Pravapishti. What I use in this is the combination of Napkesha, Lodra, and Amalki. I have seen that any case which is having bleeding, be it nasal bleeding or be it parectal bleeding or maybe hematuria, Napkesha, Lodra, Amalki. This combination works beautifully. I prescribe this in 1:1:1 proportions, 1 gram in one dose. And you can use it with Navneet and sugar in morning, afternoon, and evening. It is having awesome relief in these conditions. So these are some medicines which you should use for Raktastambhana. Then there is Patya Patya. What kind of diet or what kind of routine that patient should follow is very important in this condition because see Parikharthika or Arsha, these particular disorders are caused because of lifestyle changes and it is very important to mention Patya and Patya to the patients. So patient should have Lagu Ahar, then he should have Vatanurumuk Ahar and Vihar in his diets. Goghrita, Godugda, Navnit, Patol, or Sudanam. These are the vegetables that he can have in his diet. Okay, this is Patya. And Apatya is Veg Vidharam, Maithun, riding too long, You can see that most of the drivers, the people who are in the profession of driving, are having this kind of disorders very often. So that is one of the apatya. Sitting in Utkatasana or improper positions. Krodha or some psychological disturbances should be avoided. And there is a Guru Ahar Sevan, Ati Dikshna or Ati Ruksha or Lavan Ahar Sevan, and Ati Vam. This thing should be avoided. Okay. When you advise patient, there is one thing you can say. Generally, patient in these cases having dehydration, or they are very, what you can say, uh, they consume little amount of water. So you can advise patient to have water in good proportions, so that it can cause proper motion of the defecations. And second thing is, you can advise patient to have some exercise in the morning, because exercise facilitates your gastric motions, and then patient will be relieved in these particular symptoms. Also, you should look at the addictions of the patient. If patient is addicted to alcohol or tobacco consumption, you should advise patient to restrict those things too. Okay, so that is very important. So that was my session. Thank you everybody for listening, and I will be waiting for question and answer sessions later. Thank you. Over to you, sir.
So friends, anal fissure is a condition with patient comes running to the doctor rather than a case of piles. Piles may be with painful, maybe with painless, but whenever there is anal fissure, there is severe pain. Patient cannot bear it at the extent. With this picture, we can assume how is the pain. So, as Sonone sir very well explained the Ayurvedic terminology of fissure, that is Parikharthika. Anal fissure is a linear oval shaped ulcer in the squamous epithelium of the anal canal distal to the dentate line. We can see this picture. Etiology, main predominant factor is constipation. There is relatively fixed anococcygeal ligament at the posteriorly, and due to the excessive straining, there is a small tear in the posterior side of anal canal. It is said that there is relatively tissue ischemia, picosity of branches of the inferior rectal artery. There is lack of, and that's why the wound is not healing well. Classification, in the classification, acute, chronic. Acute is to be assumed that the fissure less than 6 weeks, chronic greater than 6 weeks. Again, deep fissure. Deep fissure is seen with the main triad, including ulcerative edges, distal skin tag, that is called as sentinel pile, and proximally hypertrophic anal papilla. Here we can see hypertrophic anal papilla at the proximal side. Here, this is the ulcer. This is, we can say this chronic ulcer, and this is the sentinel pile. Location wise, posteriorly 75%, anteriorly 25%, and both anterior and posterior side there is 3%. It is said. Again, there are some associated conditions in Crohn's disease, trauma, tuberculosis, syphilis, AIDS, and anal carcinoma. We can see anal fissures. Symptoms just described like anal fissure. There is a pain. This is the main symptom. During defecation may last for severe minutes to the hours. In my patient examination, I do ask patients the history, how long your pain is there, so that we can assume the condition of the anal fissure. What is the condition? Like pain is like knife cutting or pricking like thorn. Patient is saying that Dr. Kata chube jaisa dard hota hai. Some patients are saying that there is burning pain. Rectal bleeding is very minimal or may be seen as a straight line in the stool. And in chronic cases, we can see pruritus also. Physical exam, we can visually examine that part, making partition of buttocks. There is sometimes there is so pain that patient is not allowing you to touch even their buttocks also. We can see the position of fissure, where it is anteriorly or posteriorly, where it is acute or chronic. Proctoscopy and sigmoidoscopy is of little value, I think, because of spasm. If there is spasm, you can't insert your single finger also. Even though we apply xylocaine jelly, some patients are not relieving. So what I'm saying that in acute setting, when there is a strong suspicion of secondary pathology, examination can be done under anesthesia or when surgery is being undertaken. Differential diagnosis. When a patient complains of pain in ano, most of the cases are coming to doctors with only complaining of piles. I am complaining of piles, but what are the other associated symptoms? So we can assume some of the diseases just like perianal abscess, anal fistula, grade 3 hemorrhoids with acute fissure with severe spasm, and sometimes anal carcinoma also. Inflammatory bowel diseases, sexually transmitted diseases just like syphilis, human papilloma virus, ulcerations, carcinoma I have told. And in elderly, particularly in female patients, we may see obstructed defecation syndrome, where there are ulcers. I will show you that pictures. And there are some atypical fissures, painless, non-healing. For that, other evaluation via examination is possible, biopsy and cultures. For syphilis, we may, as Sanghavi sir says, a Khan test, we may serology also. I'm showing you, instead of telling only clinical things, I'm showing you the actual pictures, what type of fissures we may see across our practice. Students may get beneficial. Many practitioners are seeing lots of cases. This is a case of acute fissure in ano. We are seeing the edges superficially. Some part of internal sphincter is seen there. This is somehow chronic fissure, 6 months to 1 years of chronicity. We may see the sentinel piles at the 6 o'clock. Here anterior fissure with sentinel pile. This is chronic fissure. Both side, anterior and posterior. Anterior side is very inflamed. This is the chronic condition where patient is unable to walk, unable to sit. At that time, patient comes. She was in her 50s, and what we say that acute on chronic condition. Sanghavi sir says it clinical acute fissure, chronic fissure, and clinical in clinical type acute on chronic. At that time, patient is bearing this disease whole life, but whenever there is unbearable pain, severe pain, at the time patient is coming to the hospital. Again, this is chronic condition. We may see the hypertrophied edges of chronic fissure, and in acute condition, after defecation, the blood is coming vigorously. Severe pain. We may see here anterior and posterior fissure with sentinel piles. These are all pictures taken in lithotomic positions. This picture is of patient of 15 years female. Here, see the chronicity. In my practice, I am seeing patients from 1 year to 5 year, 8 year, 15 years associated with fissure, piles. Many many people are assuming that this disease is of elderly only, but it is not. Nowadays, small children are eating Maggie, bakery items, biscuits, cakes, less consuming less of water, consuming less fiber diet. What I am saying that to their parents, eat more fiber, let children eat two in your plate from childhood so that they will have a good habit. So this is a case of 15 years female with sentinel tags with fissure with anterior side. This is not only hypertrophic papilla, but this was associated with grade 4 hemorrhoids with chronic fissure in ano. Again, this is same condition, both side fissure, chronic fissure with hypertrophic edges with sentinel piles. These are all my particularly my in hospital slides taken in my hospital of my own patients. There are few 3 or 4 slides taken as a book reference. This is a condition where we can say secondary piles associated in Crohn's disease, just like Dr. Sonone has described that Grahani and other associated diseases, we may find this type of fissures. There is no constipation, but due to the forceful uh, interferer bowel habit, we can see in that patients sometimes watery, sometimes constipation, and pain is more. Anorectal infection caused by the herpes simplex virus. Inspection, palpation, and then proctoscopic examination we may proceed. By inspecting, we can see some viral pustules, herpes simplex virus, pustules we can see. And in these conditions, we may see the pain not only even after defecation, but it persists a whole day also. Even many cases or chronic cases in viral infections, there may not pain, but there is some slight itching. Patient is coming to the doctor and complaining pain and itching at the anal side. While inspection, this is a female of 50s. While inspection, especially in ladies of Maharashtra's wearing Nawari sari, we may see intertrigo. That is, due to the tight sari, there is somewhat chronic fungal infection. काटा चुभे जैसा दर्द होता है. This is not only due to the fissure, but here is actually kata. Fish bone. This is a classical case. In my 20 years practice, I have seen 2 patients in a same month coming with fish bone. Chronic case of fissure in ano associated with second degree hemorrhoids with diabetes mellitus. Patient came in my OPD, was not able to sit, saying that, sir, there is a pain, severe pain since 2 days. I cannot sleep. Just I saw there is a fish bone. And in OPD only, I was able to remove it with the help of only lignocaine jelly and artery forceps. There was no operative procedure at that time particularly. Conservative part includes the management in acute and chronic fissure, that is the management of defecation. Stool softness are more important, and above almost more than 50% patients may respond with non-operative management. I am suggesting them high fiber diet, increase water intake, increase intake of laxatives, sitz bath, salt softeners with associated with fiber, or some Ayurvedic drugs also we can take. Ayurvedic medicated oil therapy, just Sononesa described, Basti, anal dilators are also helpful in this condition. And again, in the treatment of part, Sanghavi sir will take, otherwise I will tell you later on. Just a minute. So the application of local anesthetics, just like lignocaine jelly, lidocaine jelly, and metronidazole with antibiotic ointments are more effective. Uh, and now my main part, operative treatment. To whom we should take the patient for operates? Those whom we are tried our conservative treatment is failure, there is sentinel pile. So surgical excision of sentinel pile and fibrous polyps relieve symptoms and offers good healing. Has been described initially methods of the treatment. Okay. So there is non-surgical treatment, but parasurgical. Some surgeons are managing this with under sedation or under general anesthesia also. Butox therapy, butadiene oxide, binds with presynaptic nerve terminal at the neuromuscular junction, prevent relapse of acetylcholine, temporary muscle paralysis is there. And this is assume that treat, second line of treatment in chronic anal fissures. But side effects are perianal hematoma, seen less, pain minimal with the help of 26 or 27 of syringe and needles. Sepsis if we don't take proper care of hygiene, and it's more costly. I am not using this. Controlled anal dilatation. Initially, there was a main treatment for anal fissures and other diseases, that anal dilatation. But nowadays, there is somewhat difference. The control anal dilatation means you should not do the vague dilatation, because after doing the vague dilatation, we may rupture some fibers of internal sphincters and even external sphincters, so that there may be incontinence, there may be partial paralysis of the anal muscles. Still practicing in some centers, not in Western countries. Surgical treatment, the main part, lateral internal sphincterotomy with excision of sentinel piles and fibrous anal polyps. Lateral internal sphincterotomy is doing with two methods, open method and closed method. That is tailored, open method is tailored. Second line, laser sphincterotomy. Some surgeons are saying that sphincterolysis, laser sphincterolysis. In American Society of Colorectal Surgeons, it is choice of surgery, and healing rate is more than 90%. This is diagrammatic presentation of left lateral sphincterotomy, open method. Some fibers are, incision is taken. In this picture, this is shown that we should take at 3 o'clock, but in my practice, I am taking 4 to 5 o'clock, because to avoid the anal cushions, hemorrhoidal cushions. Incision is taken submucosally in the space of intersphincteric space. The internal sphincter lower one-third fibers are picked up with artery forceps, and inside with knife, cautery, or laser, whatever you may stitch the wound or may not. Here we are seeing video of open lateral internal sphincterotomy. I am palpating it in intersphincteric groove. 11 number blade knife is taken and just incision of 0.5 centimeters or 5 millimeters is taken at the level of 4 or 5 o'clock, dividing mucosa from the internal sphincter. With the help of artery forceps, I am lifting the fibers of internal sphincter. We can see the white fibers. Fibers of internal sphincters are seen in white color and of external sphincters are in red color. Media volume. Again, if there are remaining fibers, we can check it and lift it and we can cut it. In your practice, we have experience of the tone of muscle, how much the fiber should be cut. If there is a lax tone, we can't take that patient for sphincterotomy. Then I am excising the sentinel pile with the help of cautery. This patient was in lithotomy position and given saddle block. I have not injected lignocaine or with adrenaline any solution here. So you can see some minimal bleeding there, but it can be stopped with the help of gauze pack. I'm cauterizing the hypertrophied papilla, not in the base of the, but associated side also we are taking care of. What I am saying that cosmetic surgery of anal. Here I have closed that wound, just taking suture with the help of rapid vicryl. Then next case of laser sphincterolysis or sphincterotomy. Patient is in lithotomy condition, given saddle anesthesia. Here I am injecting distilled water, cold distilled water in intersphincteric space to elevate the mucosa. And with the help of handpiece diode laser, I am delivering the energy to the internal sphincter muscle. Here, precaution is to be taken not to burn the mucosa. Here, I am delivering energy of 50 to 100 joules only. We are not making any wound in the intersphincteric groove. This is so cosmetic procedure, so easy procedure, so painless procedure. Those who have experienced are known with it. Some surgeons are telling that there is no use of laser surgery in fissure, but whenever there is a patient who doesn't want to do any wound to his body, in this case, this laser sphincterotomy is very nice. I am burning the edges of fissure with diode laser. And we can see the final output of the case. See, no wound, no bleeding, patient goes happily after come out from the anesthesia. I am sending the patients after 6 hours. Again, I am showing some cases, pre-operative and post-operative. Majority cases are done with laser also. This is a case of lactating mother who had delivered just 3 weeks before. We are seeing the hypertrophied sentinel piles. How much she had uh, beared the pain in whole her pregnancy period. Patient is in lithotomy, and I have done laser sphincterotomy plus excision of both the sides. Here, with the help of laser, there is less tissue damage and less tissue burning, so that pain is very less, and almost my patients are healing within 20 to 25 days after doing laser surgery. Same case with the both side there is sentinel piles. We can see this chronic ulcer with somehow developed pile component also, hemorrhoid component also. The whole thing I have excised, and this is the final appearance. The same day patient goes at home. Then the third type, excision of fissure and mucocutaneous flaps, indicated in absence of sphincter hypertonia, just I said, where there is no sphincter tone or no dilatation needed. We can excise the fissure base with all triad, that is sentinel pile, edges of chronic fissure, and the hypertrophied papilla. We can excise. Sometimes in chronic and hypertonic cases, this is combined with left lateral sphincterotomy also. And we may do Iceland or sliding advancement flap in these cases. In this picture, this is shown that this all, as I described, sentinel pile, edges of all fissure, and this hypertrophic papilla is excised. If there is stone, no need of doing any dilatation or any sphincterotomy. And we may cover that mucocutaneous flap also, and patient is discharged in same condition also, same day also. Here is mucocutaneous flap. What if there is recurrence even after left lateral sphincterotomy? Anal manometry, endoanal ultrasonography are essential. Separate patients with low and high resting anal pressure. Separate, we can separate that patients. And if there is hypertone again, we may repeat left lateral sphincterotomy in either side also, opposite side also. Complications of anal fissure. What are the complications of the anal fissure? Just I said, I am saying to the patient, आपको ठीक होना है, permanently ठीक होना है, तो you go for surgery, or you may live with the disease, with the complications throughout your life as much as you can bear. Pruritus any skin infection, infection of that part, and ischiorectal fossa, abscesses, fistula in ano, some are complications of anal fissure. I'm showing you some cases of this complication. What if the patient is not taken proper treatment in right time? This is a young lady, educated lady, comes with chronic fissure in ano, severe pain, chronic fissure in ano with sentinel tag. We may see the fungal infection. In female, vagina is just closer to the anus, just 3 to 4 centimeters apart, and the discharge is coming. If there is not taken proper care of hygiene, we may see the conditions like this. And even in menstruating ladies, they should have take cotton napkins for sanitization so that this condition will not occur there. post-operative result. In this, like these conditions, we should do the procedures after covering these skin conditions. But this condition was extreme, so I taken these patients only just after 3 days of treatment. This is severe chronicity case. History of 2 operates done, female patient. See the chronicity, fibrosity, and we are seeing this fistula tract also. Fistula probe is coming through. We can see hypertrophic papilla, chronic sentinel pile. Same case in anterior side also we can see this hypertrophic papilla attached with this sentinel anterior side of sentinel pile, and after anesthesia, after I am doing this case, excising this papilla, initially I was thought that there should be a pile mass, but that was not pile mass. See the long size of hypertrophic anal papilla, which was tucked because of before surgical failure. This was the final appearance. This patient also discharged same day after 6 hours. Here we can see pus. This patient was told 6 months before the surgery for chronic sentinel pile with fissure, but she came after 6 months with abscess, pus discharge. We are seeing this fissure fistula at the anterior side. Again, this case was advised 5 years before surgery for fissure in ano, but after 5 years with fissure, she developed some hemorrhoid component also, and she came with abscess, perianal abscess. Just I drained from this side and later on excised whole abscess cavity and fissure sentinel pile also. See, in complications of fissure, I am showing you this slide. This is a slide of fistula in ano. Why I am showing this slide? Here, I am showing you a MRI report of this patient. Because of neglecting anal fissure, this was a young lady of 30s. There was a surgical failure previously. After 6 months with this condition, after surgery 6 months, she was having non-healing ulcer in her right buttock. After examining, I felt there is a internal opening just at the level of fissure side. It was mentioned 4 to 5 millimeter from the anal verge in MRI report also. See, this was the internal opening. The infection crosses through intersphincteric space, travels transsphincteric, and the pus cavity, pus travels throughout ischiorectal fossa. See, here is mentioned that internal opening is at the level of 6 o'clock, 4 to 5 millimeters above the level of anal. This is a slide of anal growth. Sometimes we may assume that there is a fissure with sentinel pile or hypertrophic pile or thrombus piles. But friends, this is squamous cell carcinoma, comes after biopsy report. Thank you.
Yes, sir. Thank you very much.
Sir?
Yes, sir. Yes, sir. Thank you very much, sir.
Hello?
Sir. Kalkar, sir.
There is no voice.
Yes, yes. I can hear, sir.
Hello?
Hello.
Kunal sir, there is no voice.
येतोय sir. आवाज येतोय आता? Solanki sir, can you hear me?
Yeah, Kunal, I can hear.
Yeah. Very nice presentation, Ajit sir. Thank you very much. So I think because of some technical problems, Sanghavi sir is not able to attach. So I request to Solanki sir and Alok sir to communicate, to ask the questions, and be as a monitor. So I request to Solanki sir and Alok sir. Alok sir is here. Alok sir,
Uh,
1 second, sir.
Praveen Gore sir is also there.
Goro sir आहे.
Solanki sir, ha. Solanki sir, ha. Solanki sir, namaste.
Namaskar, Ajit. Dr. Kunal.
Sir.
Yeah.
Hello.
Sir, I can hear, sir.
By the time we connect to Dr. Alok.
Yes, sir.
Hello, Alok.
Yes, sir. Good afternoon.
Yeah. Good afternoon. And before we start, I think question answer session, let me have a minute about these two youngsters who presented today about the Fissure. Firstly, Dr. Abhinav Sonavne. It was a very good presentation, made and presented well. I'm happy about both these youngsters that they had given a very comprehensive presentation about a disease known as a Fissure in Anu. Dr. Sonavne covered, he has not left a single thing, I think, through Ayurveda point of view, covering the Parikharthika Vyadhi. And he had given us a wide range of conservative treatment available in Ayurveda. And that's why I think we understand why public at large, they turn towards the Ayurveda faculty for treatment of such disease, especially a painful disease like Fissure. So he had covered beautifully everything, right from the causes to sign symptoms to conservative line of treatment. Dr. Ajit Khalkar, another youngsters coming up on the horizon. I'm very glad about him for his good presentation. And he has also covered, apart from conservative line of treatment, he covered all the surgical line of treatment, right from the anal dilatation, which is become obsolete, but there are still surgeons who are doing anal dilatation and satisfied with it. But lateral sphincterotomy is the norm nowadays treatment of the Fissure. He had shown that. Also, he had demonstrated. And Ajit, that is a very good presentation when you present the photograph of the patient and videos of the surgical procedures, be it sphincterotomy, use of lasers. Yeah. Also, he had covered the complicated cases, also including some of the infective like fungal infection to the carcinoma patient also you had shown. So both the youngsters, they deserve my compliment, and it was a very well made presentation. Now